go ahead and get started. So thanks everybody for joining us tonight for the 8th month of this year anyway, for our Clinical Fellow Case Conference. The exciting news, of course, Elliot just mentioned, is that we will start to have some publications of this, which is very exciting. I'm getting outreach from outside entities about our case conferences. Word is getting out of how interesting they are and the great discussions we're having. So I'm very pleased about that.
And you know why that is, David? I have to jump in.
There we are.
The fellows, the MS Society fellows have been fabulous.
Right.
No pressure, loosen your tie. I mean, you know why? They're like you, they're relaxed, they're chilling, they're kicking back, and they just go. And that's really the issue. The fellows have been amazing.
Indeed, I completely agree. Great presentations, great discussion. So I'm going to stop, and David, take it away. Thank you.
Okay, and I will jump off so you're not seeing me, and Kathy's gone, and Elliot's gone, but we'll jump in periodically, David, and just let you go ahead and give it a go.
Great, can everybody see my case there?
Yeah, we've got you on top, and the slide on.
Thank you so much. Thank you so much for having me here today. I'm really excited to get all the feedback. I'm really honored everybody's joined. So I'm going to present a case. Given the previous clever titles, I tried to come up with one myself, but I borrowed it from a paper that we'll get to later today. So starting off, we had a 57-year-old male patient. He has past medical history of bipolar disorder, depression, anxiety, and migraines, and he has pretty severe bipolar disorder on treatment with lithium and antipsychotics throughout the years. This is an initial MRI. We'll get to it in a moment. So he presented back in 2010 to a neurologist in Virginia with a first event of bilateral lower extremity numbness. That was around April. And then later on that year, he had perineal numbness, urinary retention, and occurring in September. And again, worked up by a neurologist, found the MRI of the brain that we saw back here, and a T-spine MRI that showed multiple lesions that were consistent with demyelinating disease. He underwent a LP, which showed 4 unique oligoclonal bands, and the diagnosis of relapsing remitting multiple sclerosis was made back in 2010.
Very nice, David. If you want, don't change the slide, but if you could just comment just very briefly about the morphology of the lesions. What are the characteristics, just for the novices on, that suggested you could go right to and say, gee, very consistent. You know, we got a differential, but very reminiscent of demyelinating disease. Maybe you could just, for the medical students, few of the residents, the novices, just to be sure.
Certainly. So we have short segment transverse myelitis, which are lateralized. And if I had the axial cuts also, you'd be able to see the way in which they lateralize really decreases our differential in terms of the morphology of the lesions. And then in addition to that, showing the evidence of inflammation in the spinal fluid analysis with the multiple events, and then the brain imaging, also showing a juxtacortical lesion. All of that was supportive of multiple.
Yeah, so short segment skip lesions, and as you mentioned, myelitis. And in a lot of these cases, a lot of people like to sometimes differentiate between partial myelitis, as you pointed out and underscored. If you had the axials, you could see where they are left or right. But in terms of partial myelitis, rather than a true confluent transverse myelitis through and through, which can occur in MS, but is much less common, particularly to cut across the gray and white compartments.
Yeah. Okay. Wonderful.
David, and this is Esther Malamed. And just for the purposes of our trainees, do you want to comment on what other studies you would have done in this patient if you were evaluating them for the first time in order to solidify the diagnosis of MS?
Sure. Let's see. So if we saw this gentleman back in, I guess things would have been a little bit different back in 2010, but if this gentleman came to my clinic now with predominantly spinal cord disease, he would have been over 50 years old at the time. I still think it would have been reasonable to rule out any other inflammatory etiologies, including NMO and MOG. I know 11% of cases of NMO can present with short segment short segment myelitis. Reasonable to rule out copper, HTLV, and then a thorough history regarding any other risks of autoimmune symptoms, for example, which given that Sjogren syndrome can also present similarly. I presented the brain and the T-spine. There's a C-spine, which I think would be reasonable as well. And then to focus on the examination to see if we're dealing with upper or lower motor neuron symptoms and whether or not B12 should it also be evaluated. I guess things could have been pretty different in about 10 or 8 years ago at this point.
Yeah, but I love the fact that you brought up the issue about NMO, because once you have a molecular diagnostic capability like NMO-IgG, not perfect as sensitivity is probably still in the 50 to 80% range, that once you have positivity and you have that molecular detection test, then it changes your thinking about things. The Wingerchuk clinical criteria is fabulous, but there are exceptions. Just like correspondingly, there's reciprocal opposite, that some MS patients have long, more confluent lesions that some cases may have started off as skip lesions, but they were in contiguous levels, so eventually they became more confluent or juxtapositioned and then fused. And just like you mentioned, that NMO, a certain small percentage of them, maybe 8 to 10% can have these short segment lesions. By the way, I've seen some of these in patients with NMO-IgG positivity that had short segment, and their next myelitis was 8 segments. So some of it also depends upon when they present. And if they had a lesion without a remarkable first syndrome, they may not have even been evaluated. And then finally, I was glad to hear you talk about HTLV1, and for the novices in the group, human T-cell lymphoma virus, or HTLV1/2 associated myelopathy, or HAM. HAM TSP, one of the older names is tropical spastic paraparesis. Gene, I know you're here with us. Any update or any comment about where we are with HAM TSP or HTLV1? I know that David brought it up, and I think that's a good idea.
That's a whole other discussion. We have Steve Jacobson in the group, on campus at the NIH, and he's the one who focuses a lot of attention on that. I think there's a lot about, and I really can't address that, a lot about the T-cell immune responses associated with that disease. I'd be glad to actually put together maybe a paragraph or so and send it to you if you think somewhere inserted into, this particular presentation might be helpful.
David, in your experience, has there been any progress in treatment of it that we know of?
No.
Yeah, I didn't think so.
No, nothing.
Okay, David, sorry, I'll keep going. I'm going to let you go. I didn't think so either, but these are very good.
Elliot?
Yes.
Elliot, this is Andrew Goodman. I could just comment a bit
Please.
On HTLV1 associated myelopathy. So it's really a myelopathy, and clinically it doesn't present as acute transverse myelitis. It's generally a chronic progressive myelopathy. So it doesn't present like this.
Yeah,
usually.
Agreed. And I've had
So I generally wouldn't go after that unless there was a particular circumstance, like the person was from an endemic area, be it Japan or the Indies, that sort of thing.
Or a friend of ours was visiting Caribbean Basin and got really,
that's right.
really drunk and out of control. Right. Visited the prostitutes down in Jamaica or something, right? Does happen.
Same thing would be true also for copper myelopathy. It's, skip lesions like this, and acute course would be unusual, I would think, for that.
Right.
Yes, but if you read the literature,
to put in a plug.
You will see that there are a few copper related CNS disorders which not only have been acute, but there have also been a few papers probably about 10 years ago on copper related acute presentations of optic neuritis. I would not have expected that, but it is in the literature. Now the question is, are they coincident, or is it really?
Do you see bands with copper? I can't say that I've ever been aware of that.
I don't recall what the workup was at that time, but you know what? I will, for the purpose and edification of the group, I'll send it to Doris, that answer, and ask everybody to be informed on that. So again, is copper associated optic neuritis. I think a few of these were actually in the pediatric age population, which I thought also was very unusual. But anyway, so and it didn't raise the question of like, Menkes or any of these others, which can be involved with copper and others. But anyway, I will find out. David, you're back on. I'm sorry.
All right, thank you. Thanks for all the thoughts. So this gentleman back in 2010 was initially started on Avonex treatment, and maybe not so unsurprisingly had severe depression on that, headaches. He really only was able to tolerate treatment for a few weeks, at which point he was transitioned to Copaxone therapy. So between 2010 and 2011, he tolerated that well, but unfortunately had a new event with a new T-spine lesion at the end of 2011, and he was transitioned to natalizumab. He was transitioned specifically to every 4-week treatment. And then around 2014 is actually when he started seeing us at UVA. I know that a lot of the MS centers around the country will be used intermittently by the community providers to come visit. So this gentleman was seeing us every year, every 6 months or so, as well as his local neurologist in rural Virginia. And so around 2014, he was transitioned to extended interval dosing natalizumab. And I'm going to go into a little bit of the details on that, recognizing, Dr. Frohman, that you're the last author or the senior author on a good load of these papers. So please feel free to chime in.
No, hold on. I would have to beg to differ that I'm co-senior with Gene Major, and usually the second on that is Teresa Frohman, the better 7/8 sitting to my left. So, yeah. So you've got 3 of us on.
All right, wonderful. I'll do my best. So
David, at this point was, this is Esther Melamed. At this point, was JCV antibody information available for the patient?
By 2014, we did have a titer. I was holding it secret for the moment, but I'm happy to share. At this point in his treatment course, he was at 1.77.
Yeah, and we would assume that part of the decision for extended interval dosing had something to do with that. And I guess you're going to define soon what your particular interval was, because people consider extended interval dosing different things. For us, for example, it's 8 weeks. We know some people around the world that consider 4 weeks and 3 days extended interval dosing. We don't consider that, but we usually would dose people at 8-week dosing, but I know people have other regimens.
Yeah, so the first, or at least the first that I was able to find investigation about changing the way in which natalizumab was dosed was by Kilstein et al., and they found that in 7 patients out of the 10, which they held the natalizumab for 6 months, they had clinical or radiographic relapses. So straight up holding natalizumab for 6 months turned out not to be a tolerable treatment in order to decrease.
David, was this drug holiday a convenience holiday because it occurred after February the 28th, 2005, that fateful Monday when the drug was taken off the market? And this is the Dutch group, and I happen to know that the Dutch group published this finding. So were they really doing a holiday, or was that the drug was taken off the market, they decided to sort of say, okay, let's see what happens, rather than a true holiday? Because we did have data from the phase 2 study. That was the David Miller first author, New England Journal of Medicine. And in the phase 2, we knew nothing really happened after 4, after 8. It was really after 12 to 16 weeks that we saw recrudescence clinically and radiographically. So I'm just wondering, what's the date of this Annals of Neurology paper?
It was a 2010 paper, but yeah, I don't recall them saying specifically that they were holding it for that reason.
Yeah, interesting. Because we learned a lot about this a number of years before, so I'm wondering why they did this.
And then I think primarily, I'm going to start quoting some more of your work, or I guess all of your work, coming up here, Doctors Major and Frohman. The thought process behind extended interval dosing is that there are multiple factors that play a role in the saturation of the integrin receptor, including metabolism, or excuse me, including serum concentration variables, metabolism, body mass, dosage, dose frequency. And so we know that the standard treatment is 300 milligrams every 4 weeks. And a paper from, let's see, this is, I guess I don't have the year here. The Bompresi paper, it was a retrospective analysis that looked at efficacy in 6 to 8 week extended interval dosing. And so they had 361 patients total, of which 96 of them were extended interval dosage. And they found that the relapse rate, including clinical and MRI activity, were both similar, 13% between the two in a clinical relapse. And then MRI activity was 11% in the regular dosing, 9% in the extended interval dosing. So fairly comparable finding. And I think this led to your, or at least it preceded your much larger study. This is up top, the poster that was presented in 2014 and then followed up by the paper in 2016, and details of it, specifically retrospective study that evaluated 3 different definitions of extended interval, as you were getting at before. So early extended interval, late extended interval, and variable. So early extended interval was defined as treatment every 4 weeks and 3 days up to 6 weeks and 6 days. Late extended interval was 7 weeks up to 8 weeks and 5 days, and then variable extended dosing, which was alternating between the two of those. Those were all compared to, there's about, let's see, 250 in the first group, 275 in the middle group, 382 in the variable group, and then over 1,000 patients were compared that were receiving standard interval dosing. And it was found that dosing intervals up to 8 weeks and 5 days did not change the efficacy of natalizumab. There were no cases of PML in the extended interval group, and there were 4 in the standard interval treatment. So the conclusion, and then there was 62% versus 61% evidence of no clinical radiographic disease in the extended interval versus the standard dosing patients. So overall, it was really deemed a success. Please.
This is Gene. So that this was kind of the tipping point where the extended dosing protocols were solely to address the issue of the risk of PML. And so, of course, as we all know, there's a temporal relationship between the number of doses of natalizumab an MS patient receives and the incidence of PML. And so the thought process going on here was one that, you know, if you would extend the dose and the pharmacokinetics would be similar, then you should be able to, you may be able to reduce the risk of PML. And that's still an ongoing study. And my understanding is that there still is not a clear idea as to whether or not the extending dosage, whether, as Elliot had pointed out, is it 6 weeks, is it 8 weeks, is it 4 weeks and 3 days? Does that have the same clinical benefit for MS as the standard 4-week dosage? And I know that the company is very interested in this. They've been holding workshop sessions around and about to discuss this and looking at ways to be able to develop the data to, more importantly, show that the clinical efficacy of extended dosing is equal to the standard dosing. And if the risk of PML is less, then so be it. And that was really the data that they presented. When was it, Elliot, at the ACTRIMS meeting in San Diego?
Correct.
And I would like to just make one very short comment, and that is, in the grand scheme of all of these things, efficacy is important. But if you think about all of us on the line who care for patients, even if there was a small compromise in efficacy, what are you most concerned about? An MS attack or PML? I think we all know what the answer to that question is. So I'll let you just continue, David.
All right, great. Thank you all for your thoughts on this. So back to our case, I just want to bring our gentleman's MRI to the forefront. This was the September 2017 MRI. Brains, he doesn't have that much pathology in his brain, as you can see. And there's not a lot of structural abnormality here. Certainly, volumetric studies might find some atrophy, but cerebral atrophy. But overall, I'm not bringing to your attention anything at this point, but it's other than a fairly normal-looking brain with a little bit of demyelinating disease. So he was stable up until January of 2018. And on January 15th, he started having new dysarthria. January 30th, he was reported to have increasing unsteadiness. His natalizumab was infused on the 30th of January. In early February, everything kind of came to a halt for him. He was ambulatory, he worked at a factory, and he was unable to stand anymore on February 7th. He left work, he got admitted to an outside hospital. They performed an MRI of his brain. It was reported as unchanged, and he was admitted for a MS relapse. He was treated with IV methylprednisolone. He got 1,000 milligrams a day for 6.5 days. What happened was he was not improving at all. He was waiting on going to inpatient rehab, and they continued to administer 1,000 milligrams daily until ultimately his IV blew halfway through the 7th dose, and that's why the dose is kind of curious at 6,500 milligrams. But again, he had no clinical improvement throughout that treatment. He ultimately went to rehab, and his wife called our team on March 1st and told me, he had just had an MRI, did he need to have another one? And that's when it came to my attention that he had been admitted to the hospital, that all of this had even been going on. And so we got him urgently into our clinic. We did review his MRI from February 9th. Ultimately, I'm not going to draw our attention to the conclusion quite yet, but I will say that there are some changes, and that there were no areas of enhancement appreciated on this MRI at this time. My eye was brought to the cerebellum, but I will say that I did not fully appreciate the pathology yet at this point.
By the way, David, is there a lesion in the ventral medial pons?
Right.
Is this real? Is that what you're asking?
Yeah.
We did not think so.
Okay.
It was not clear on the True T2. And if Dr. wants to comment too, I think she's on the phone here. We stared at that image for a long time and decided the best plan of action would be repeat the MRI to try and determine if there was anything going on up there.
Now this is FLAIR, so usually for infratentorial, did you have a T2 axial at the same level, and was there conspiguity on the T2 or no?
Yeah, precisely. There was not, and so there was no clear evidence that it was visible in any other sequence.
Okay.
Can you hear me?
Yes.
Okay. Yeah, this is Mila Goldman. So I was just gonna, and I'm David's mentor and was engaged in caring for this patient. And so yeah, to add to underscore David's point that we couldn't find a clinically associated MRI. We couldn't find an MRI correlate to what appeared to be his clinical presentation at the time. So that pontine lesion did not appear to be real, as David explained. And again, within the cerebellum itself, there was not any obvious pathology, that was consistent with, disease activity or disease progression. I think, is it the next one, David, where we have that punctate area?
No, I'm going to give his exam next.
Got it. Okay, so carry on before I steal your thunder.
Yeah, so I'll add, Dr. Goldman and I had not seen the patient yet at this point.
Oh, yeah,
so we were doing our best to localize off of the wife's story that she called me.
This was sent. Yeah, this was done in an outside hospital, sent to us through PACS, and contacted. And then to further complicate the course, just as a point of interest, this patient actually belonged to an attending who had left our practice December 29th. So while this patient was being co-managed with a local neurologist, this patient was being managed with another physician at UVA who was no longer here. So this patient was completely unknown to me at that juncture as well. So lots of moving parts.
So we decided the best course of action was to get him in ASAP. And so my exam of him the following Monday, again, the history was unchanged. He and the wife agreed that he had had no worsening but no improvement with either steroids or 2 weeks of rehab. His vitals were okay. He's very anxious. He's a very anxious gentleman at baseline. So, you know, getting to know him a little bit better, that's kind of his baseline. Sitting in a wheelchair, and again, this was a gentleman who was mobile, fully ambulatory, not 2 months earlier. His exam was notable. So he's oriented. He had a slowed ataxic speech pattern. I did not appreciate nystagmus at this time. No APD. He had a delayed right shoulder shrug. He was peritonic. He had some decreased strength at the right hip and the knee flexor, slightly brisk throughout, bilateral pectoralis reflexes. He had an equivocal right toe and a downgoing left toe. And most notably, he was severely ataxic on finger to nose, heel to shin, bilaterally. It was unable to perform rapid alternating movements in his lower extremities. He had severe gait ataxia, requiring both me and his wife to move him, or to help him assist moving him from his wheelchair up to the exam table. And even with the exam table up, we had to prop up the back so that he could sit up okay.
So from your standpoint, David, where were you thinking in terms of localization or cerebellar localization for this guy, in terms of, you know, vermis, hemispheric, ventral, dorsal vermis, you know, flocculus, paraflocculus? What was your thinking about it?
Well, he had slightly more worsening on the right side. You're challenging me in an appropriate way in an area of my weakness, Dr. Furman. So I don't have a great localization within the cerebellum, but I would say profoundly he was a cerebellar presentation, and that brought our attention back to the cerebellum.
Yeah, no, I totally agree with you. Totally agree with you. But I think you very nicely pointed out, though, some of the pertinent negatives, which was there was no evidence of nystagmus. Assuming you examine, like I do, like Myla exams and Andy Goodman exams, we look at eccentric gaze. Is there a leaky neural integrator when you're in eccentric gaze? If there is, the question is, do you have flocculus involvement? Is there saccadic pursuit? Did this patient have decreased VOR cancellation? So it sounds like that wasn't involved, but it sounds like you had a lot of vermis. He couldn't stand up. He's got, you know, probably tandem ataxia, maybe more superior vermis with the legs worse than the arms, but the arms are involved as well. So the question is, does he have some vermis and some cerebellar hemisphere because of the appendicular tremor? And the heel to shin ataxia. So it's probably a little more diffuse than we might realize in some of these cases. So vermis hemispheric, but not vestibular. And if there's not saccadic dysmetria, then probably not dorsal vermis of the cerebellum. Okay.
Okay, wonderful. So I guess at this point, I'm happy to move on. I didn't know if anybody wants to toss out any ideas before we start really getting to much closer to the final solution in terms of
what you were looking with. We got Scott Zamvil on the phone. Scott, here's a guy which has a paucity of finding. I must agree with Myla and with David, a paucity of, you know, lesions with conspiguity that bring us to the localization. We got small stuff, if anything, much more characteristic lesions for demyelination. I agree, David, in the spinal cord. But it's got a really significant, profound cerebellar presentation. So the question is, he had MS. He's been on extended dosing for, we're going to find out how many total doses, one or the other. But what would be your, I mean, Scott, you're thinking about this. What are we missing? What's David missing? He's going to tell us, but.
I think it's a little bit challenging. I think, David, you got to continue, because I had already looked at the slides all the way through, so I can't go. I can't go back.
David, why don't you go to the next?
So he's so honest.
Yeah.
That's what I love about him. He's
David,
so honest.
This is Ahmed.
I think
I have a question.
Be honest.
All right, so we're going to go to the next slide.
Okay, keep going.
Okay, yeah. I think there'll be plenty to discuss.
I think Ahmed was trying to break in with a question.
Yes. My question is, David, I just was confused about the lesions that were seen on the MRI. We think they're not really, we think they are artifactual, or we think they're actually not correlating with the symptoms, but they are there. So
the dorsal pontine lesion we thought was artifactual.
And how about the cerebellar peduncle kind of can there was some maybe flare signal in there bilaterally? Or
we really weren't sure. We stared at it for a long time and just were not certain if it was real or not.
Okay.
There's also a question in the chat box from Pilar, and she wants to know if there is any question about the other causes other than MS, concern of the I'm sorry.
Paraneoplastic
Thank
process.
you. Yes.
You're welcome.
I think that that's certainly a good question and a good consideration for the differential anti-paraneoplastic disorder. I guess there's multiple causes of paraneoplastic cerebellar presentations, and it's certainly worth considering.
And can I ask a question? If you look at the image all the way to the left, and the lesion we were talking about was in the ventral pons. But if you would look in the dorsal area, those little stems, like little cherry stems, those, amazing how small they are because we think about the middle cerebellar peduncle, it's so big and beefy. But, most of the outflow tracts actually exit through the superior cerebellar peduncles, and those little stems back there, those are the SCPs, the superior cerebellar peduncles. Now, the reason why I'm bringing it up is this is flare. I don't see the corresponding T2 yet, but do those stems, those SCPs, look a little bit high signal to you, as if there might have been chronic demyelination in there? Because that certainly would be on the list of localizations for speech dysarthria, appendicular ataxia, tremor. We've certainly seen our share, and for patients who have an unusual eye movement syndrome called contrapulsion. We know about Wallenberg's, where people in a lateral or dorsolateral medullary syndrome will have overshoot hypersaccades to the side of the lesion and then undershoots to the opposite side, whereas lesions at the level of the SCP, the hook bundle of Russell, this area, give you contrapulsion, which is overshoot lesions to the other side. And you may not pick it up unless you're really looking at metrics in both directions. But anyway, the stems look a little bit pale to me. So I guess you'll show us more. I see the arrows with the punctate lesions for sure. But I just wonder about those superior cerebellar peduncles.
There was concern throughout the imaging here that there was perhaps hyperintensity flare, probably not contrast enhancement, but flare hyperintensity, specifically seen on the image, seen post-contrast, that there was a folia brightening of the folia on the outside. They did not comment specifically on the fibers. Sorry, Dr. Froman.
Okay.
Yeah, no, I was just going to add a comment. I mean, I think Dr. Froman, I think you're getting at, there's definitely not something obvious here, and I think what was striking to us sort of at this juncture and as we go forward, and I think David's going to tell us more about it, but given how sick this guy looked in a relatively short period of time, this MRI was very unsatisfactory.
Yeah.
Yeah. Okay, so carry on, David, from that sort of vantage point.
Yeah, so essentially at this point, we had two MRIs to look at. We had from February 9th, which showed no contrast enhancement. Now we've got this March 5th MRI, still nothing really bowling us over, but we did have an exam at this point that fully localized to the cerebellum. And so and so we wanted to spend a little bit more time trying to make sure we weren't missing anything. I'm just going to bring up a slightly different version here. So if we so this is the area, these are still flare, but this is the area where there was a little bit of post-contrast enhancement right here. But if you look here on the outside, this area was not nearly as bright on the pre-contrast images, this area specifically. And as you start to see, there's actually significant room here that was not appreciated on previous examinations. So I think.
And by the way, on the middle scan, David, right there, if you look at the right posterior cerebellar hemisphere posteriorly, just a little bit lateral to where you pointed out the brightness, look at the sort of like soap bubble, low signal intensity change there. Jean, looking at imaging, does this look concerning to you for some of the low signal changes that we sometimes see in PML?
Yeah, so this is getting to be kind of what I would say, out of my league here. As you describe all of these little little things here and that, and I really can't add to the conversation on this, Elliot. Quite
Okay.
honest.
Okay. So we have folial space, but that middle one in the right dorsolateral cerebellar hemisphere looks very conspicuous to me.
Yeah, and again, we were focusing our time and attention here on the cerebellum, and so
That's it.
To compare the March 5th MRI to the September 2017 MRI, we were really able to notice the stark cerebellar atrophy, specifically right worse than left. These are the old ones up top and the new ones on the bottom. Stark
Bingo.
cerebellar atrophy in comparison between the two.
Granules.
I think one thing to add, just sorry, it's taking a step back from MRI. This is Ethan. Was there any basic workup for, initially when the MRI was thought to be negative, something like thiamine deficiency or some other cause of a subacute cerebellar syndrome? I know perineoplastic was also mentioned, but
Yes.
There is a short list of MRI negative causes.
So this is actually still on the same. He did an MRI before he saw me, and then he saw me. So we would still be in that process. So I didn't send a thiamine at that time.
Okay, all right.
I think I got anchored pretty quickly. I'll admit. This gentleman had a known positive JC titer. He had new enhancement on his imaging. He had a significant clinical worsening. And so certainly he was already on extended interval dosing for treatment of his MS. And so certainly my primary concern was, let's rule out the stuff that's going to kill him. And so our concern turned to PML. So for our gentleman, specifically the data, as Dr. Froman mentioned, he got 33 treatments of Q4 week natalizumab between 2011 and 2014. And then he received Q6 week treatment from August 14 to January 2018. So an additional 32 weeks of treatment. This chart here that I've brought out is from the 2017 Lancet article that conglomerated 20,000 patients from the Stratify 2, Top Tigris, and Strata clinical studies in order to identify risk on natalizumab. And our gentleman would go right into this category right here. In terms of that, he's had 65 cumulative treatments, or maybe even a little bit higher, given that the other way to look at his data is that he's had greater than 72 consecutive months of treatment. And so I tapped him in clinic that day, no whites, no reds. He had a very slightly elevated protein for our labs, lumbar protein upper limit is 44 and a glucose of 67. And then ultimately his JC PCR came back positive. There were 31 copies from Quest. And this led, as Dr. Froman mentioned before, to a diagnosis of JC virus granule cell neuronopathy, which I'm going to go into the details of right now.
David?
Yes.
This is Mila Goldman again, David's mentor. Can I highlight a couple things for the other trainees about this case that I think were really illustrative, just to think about? So first, the MRI report from March 5th, 2017 was read as findings consistent with MS, no acute findings, no changes, because the prior MRI had been done in an outside hospital. And so this just speaks to the importance of looking at your own imaging. And when Dr. Lapidus and I saw this patient in clinic, it was so clear to us that this guy had cerebellar pathology, that we went back and we were sort of the first people to put them side by side and look at the cerebellum and say oh my gosh, there's this atrophy. Because again, this patient was new to us. The imaging was done at an outside hospital. It had been read as stable by our own UVA radiologist. And so it just speaks to the neurologic exam is so critical, and that you have to be able to connect what you're seeing in this patient and what the MRI is telling you. And if it's not obvious, you have to keep looking. And then also just underscoring the importance of looking at your own images. I think those are just some critical lessons as we move forward to talk about GNC related, that are a little bit broader in scope than the case, that you're going to sort of teach us about, David. Would you agree?
Absolutely.
Hey, by the way, Mila, I've always loved you, but today I love you even more. That is one of the more important principles that has been underscored in the entire 8 months that we've had this national webinar. Please, please, please always look at your own films and put them up, and not just this one and last month's, but my wife is actually like the cheerleader in the back going up and down, because we had a patient recently who had her medicine changed based on actually a radiologist correct reading of the current versus last year's. Hey, there's 3 new lesions. The problem is that radiologist didn't pull up the year before those exact 3 lesions, not enhancing, were present previously. So this poor patient goes from 1 DMT, completely stable. You're not going to like this, Mila. Goes on Ocrevus, and she's somebody I really believe had a partial Kunis reaction. I'm happy she didn't have vasospasm and die of an MI, but this was not. It was out of my hands. It happened. I was in transition from Southwestern to Austin, and these sorts of things happen. So it's so critical. What you just said is worth underscoring again, and we'll make sure that it's quoted when we go to the publication part. So thank you for that. Go ahead, David.
Yeah, David, teach us about GNC.
All right. So back and I'll mention. It seems like we have some people on the phone who are going to be significant experts on this in comparison to what I understand, and whose names are on a lot of these papers. So back in 1983, the loss of granule cell layer was described in PML patients, and this was non-HIV patients. I'm gonna stick with the HIV patient population a lot for this next chunk before we get back to MS. And then in 1992, there was noted to have this peculiar hyperchromatic nuclei that were twice as large as normal granule cells. It was only found in the granule cell layer, and it was only found in the granule cell layer where PML foci were nearby. But there was no HIV in those cells, there was no JC virus in those cells, and this was postulated to be maybe either a latent JC infection or a granule cell that had been abortively infected by JC virus, or an infection which produces a non-infectious virus. And in 1998, 10 patients with cerebellar degeneration were described in this paper, and 3 of them had neuropathology, which showed focal degeneration of the cerebellar granule cell layer. Again, they had these unusual focal axonal swellings in the brainstem, in the spinal cord. They had, at the time, it was reported that 38% of PML patients in the HIV cohort had cerebellar involvement, but at this time, this was all white matter changes. They were not describing cerebellar degeneration. They found the PML virus in one of these cases that where the pathology was investigated, but they were not certain at that time whether of the significance, and they state that in their paper. But certainly worth remarking on. And then, so it was in 2003 that there was an HIV patient who was described with a cerebellar syndrome. They had white matter changes in the bilateral cerebral white matter, consistent with PML, but then they were also noted to have cerebellar atrophy. The patient ultimately died, and pathology again showed destruction of the granule cell layer. The granule cells appeared to be enlarged. They reacted at this time with the polyoma virus capsid protein, and electron microscopy found the polyoma virus in the granule cells. There was also a positive PCR. So this was the first time, or I guess it's the second time that we're seeing the JC virus in these cells. And at this time, we still had a case where there was comorbid PML and this granule cell layer pathology still in the HIV group. And then in 2005, there were findings of granule cell pathology outside the setting of comorbid PML. Still an HIV patient, but this is where the title of my paper came from. The uninvited guest was the editorial that accompanied this paper. And accordingly, there was thought to be probably upwards of 50% of involvement of 50% of PML patients were thought to have some sort of involvement of this granule cell layer, but this was an isolated case of granule cell neuronopathy. Was somebody gonna chime in?
Not yet.
Okay. Not yet, okay. And so going into the pathology, or excuse me, getting to the meat in the MS world, in Annals 2013, there was a report of a granule cell neuronopathy in a Tysabri-treated patient. The patient had 52 monthly doses. They had ultimately were found to have 9,500 copies of JC virus per milliliter. They got 3 rounds of Plex. And 2 months later, they were getting worse still. They were found to have nystagmus. They underwent a biopsy because folks were concerned about iris. And at this point, they found decreased cells in the granule cell layer here. This panel D is a normal pathology slide. The rest of the slides are the patients. A, B, C, E, and F are all the patients. And so you can see significant loss of the granule cell layer here, but preservation of the Purkinje cell layer. And then this red staining is indicative of the presence of the JC virus in those granule cells.
So they undergo a series of swelling before they probably have a virolytic phase, and then death of granule cells, folial atrophy. I still wonder whether that right dorsolateral cerebellar hemisphere low density area is kind of a collection of these kind of almost like soap bubble lesions of alternating dropout, almost like spongiform, punctuated by cells next door that are swelling but haven't gone through lysis yet. Just a thought.
Yeah, we'll have some more. We can see. We have more images too. We can see if that persists. Okay, so at this point we've got granule cell neuronopathy associated with natalizumab treatment. And so then just a brief run through. So it's a JC virus infection of granule cell layers of the cerebellum, leading to neuronal loss, cerebellar atrophy, and clearly, as I described, it can be found with or without classic PML. There are a couple of papers that try to do their best to grab all of the case reports of these patients, and case reported causes include treatment with natalizumab. I was able to find 4 cases, not including ours. Rituximab treatment, patients with HIV/AIDS, HIV plus a hyper IgE syndrome, a CD40 ligand deficiency in a child, and then a sarcoidosis patient on prednisone. The prednisone dose was a 15 milligrams a day dose over the course of 3 months prior to the presentation.
Oh my God.
Yeah.
It should be pointed out, Elliot, that in the original pathologic description by Richardson years ago, among the patients with PML were people with sarcoid.
Yeah, amazing. Right. And we know what they were getting. But this seems like such a small dose over a not very long duration of time. But there
I'm
you go.
not sure it's the prednisone. I think it's the sarcoid.
Yeah.
That puts them at risk.
Well, right, as Joe Berger would say, and Gene might corroborate this, that the particular disease you have that you're treating with immunosuppressant or modulating drugs has a very significant role to play in the overall predilection of PML. So I would agree with that.
Yeah, and I would agree with Elliot.
Okay, David.
Okay. And so I think as pretty clear at this point, there's a chronic subacute presentation. Cerebellar syndrome is the primary manifestation in terms of ataxia, dysarthria, incoordination, and then biopsy or positive JC virus PCR with associated cerebellar atrophy is necessary for diagnosis. And I did want to spend just a moment going through treatment here, and then going through the cases real quick that have been published previously. So the first case I mentioned already is a patient who, the patient who was published in the Annals 2013, was a patient who had gotten Tysabri for 52 months and then received plasma exchange ×3, went on to develop iris and did worsen. They ultimately required bilateral aid for walking, but they stabilized. I mean, they stabilized bad, but they stabilized ultimately. Case number 2 that I have here was a 2016 case that also underwent plasma exchange. They ultimately got 5 treatments, and did also go on to develop IRIS. However, they were not clinically changed accordingly. Case number 3 was an additional plasma exchange treatment. They did not develop IRIS, and they were unchanged in terms of their disability. And the fourth case, which I go into a little bit more detail on the next page, I think it's certainly worth investigating a little bit more. It was again, a Tysabri-associated case, and in this case, they gave the patient G-CSF, and they did improve. They had a baseline EDSS of 2.5. At maximum, they got to an EDSS of 8, and ultimately returned down to an EDSS of 6.5. So they had 5,000 copies on the initial lumbar puncture. 2 months later, after their EDSS went from 7 to 8, they had 13,000 copies found, at which point the G-CSF was administered. And then 2 months later, the LP showed only 250 copies with this EDSS as I described. We solicited advice from around the country after coming, after making this diagnosis. And I don't even have all of the different options that were mentioned to us during our discussions with experts around the country, but a few of which included plasma exchange, the G-CSF, pembrolizumab, which is a T-cell proliferation and it inhibits T-cell proliferation and cytokine production. So I think it's worth noting that despite the number of cases that we've seen with PML, and even the number of cases that we have of granule cell neuronopathy, there is certainly no consensus on the treatment.
Can I ask you one question? I noticed that you listed these cases, the first 3 or 4, plasma exchange followed or concomitant with IRIS, but I don't see anything about regular steroids. And I just would like to put in a plug here, because I think when you're dealing with a known agent that can be associated with PML, like selective adhesion molecule inhibitors, and then you go through the IRIS phase. When IRIS hits, it's kind of like being on your mountain bike, David, on a 70-degree grade with no helmet, and I've disconnected your brakes. See you later. Probably by the time you have IRIS, it's too late. So the patients that I have seen with this, and the many, many I have been called about around the world, because when the first 2 patients were diagnosed, that led to the removal of the drug from the market, the San Francisco case, Stanford case, Scott Zamble knows the case, that was a Dallas family. I took care of that patient, and for some reason people thought at Biogen, well, Elliot's the expert, and of course Gene and I know there's no such thing. That's not true. But I got incredible numbers of calls, and the only thing I asked for was feedback as we were changing the equation, what would work, what would not work. And it turns out, the more you plex these people, you accelerated reconstitution, and they need to reconstitute a bit. The problem is it probably also shortened the latency to IRIS. And what we learned over time, we didn't get this, Gene knows that, we got this from our HIV colleagues, which was you need to add steroids, you need to give a sufficient dose, and you need to give it long enough. And when we started giving a gram equivalent of Solumedrol or an oral equivalent of a gram of Solumedrol once a week for 12 weeks, every other week for 6, and then monthly for 3, we basically have not had a single death on that protocol in a very large cohort of patients. And now the question is, the Karnofsky is what are they like with PML afterwards? And the question is, that has everything to do with the latency of the onset of the symptoms to when you actually start that treatment.
Right. So this is Mila. I just wanted to jump in here and add, I think one of the sort of nuances that we really struggled with in this case is what you're talking about, and the majority of the experience from the MS community is related to oligodendrocyte-centered JC viral attack. Bingo. And that this granulocyte sort of variant is potentially a different phenotype, and that the experience is not directly cross-talkable. And not every patient that has the GCN experienced IRIS, which is part of why that is teased out here. So there are patients who had the granulocyte-related JC viral infection that didn't have immune reconstitution inflammatory syndrome. And whether that has something to do with the difference in how that infection is based or not, I think is part of the unknown question. So it's not that case 1 and 2 got steroids and case 3 and case 3 and 4 or vice versa didn't, right? it may have something to do with that this is a different phenotype. I don't know if other people on the call can speak to that, but that was what we were really challenged with, is that there's very limited, we know a ton about oligodendrocyte, not a ton, but certainly relative than what we knew 10 years ago about oligodendrocyte related PML, but can we directly crosstalk that to this type of infection? I don't know, and we really struggled with that, and I think that might be an interesting point of conversation.
And I think you make an excellent point there. If you don't mind me getting just a tad molecular on this particular point. So as far as we know, and I would say that the predecessors, in particular Igor Korelnik, who brought this far more to our attention, on what's called GCN, that there are alterations or mutations in the capsid protein towards the carboxy terminal end of this thing, of the VP1, which is the attachment protein for JC. And so he pointed out to us that these alterations actually may make JC a little bit more tropic for a granular cell infection than the prototype, so to speak, that came directly from JC, which predominantly, if not almost exclusively, targets macroglial cells, obviously the oligo, and then astrocyte to less extent. So for example, now when we get samples where the neurologist says, well, I'm kind of curious because, the clinical symptomatology in this patient is predominantly motor dysfunctions, predominantly cerebellar. Is this a JC-GCN? And that is a different phenotype of the virus to some extent. And I think you're exactly correct that you have to differentiate that in what happens with IRIS. And so I'm going to have to get off the call in probably a couple of minutes. Let me just add to this then, that in response to the increasing questions we get in looking at the pathophysiology of JC infection in the brain, that with the assay that we have and trying to get as much information to you folks as we possibly can. So we have added an additional primer pair and probes that looks at this region of the viral VP1 genome that is associated exclusively with GCN. And it's multivariant. There's not one, there's multiple changes that take place. So if you were to send us a CSF in a case like this, and I don't think we had the CSF in this case, so we would be able to tell you that is JC there, how much is there, what the pathologic variant may be, and whether or not there's a concern for any changes in the VP1 that would warrant looking at more genetic sequences in that region.
So before you get off the phone, could you actually elaborate on that? Because one of the things that we discussed amongst ourselves in managing this case is the value of sequentially, of sequential tapping and CSF JC viral marking over time. Can you speak to that?
Yeah,
is that useful? Should we be tracking it? Is that informative?
Yes to all of that. Would it be informative? Absolutely. And as an example, we've been tracking a little over 100 PML cases of MS patients with natalizumab who have experienced IRIS. And well over 50% of those individuals, although clinically they may stabilize, although you can't consider it a cure, they never clear the infection. We always find a little bit of JC DNA in the CSF. Elliot pointed out, one of the index cases way back from 2005. And that individual, thanks to Elliot's and Teresa's extraordinary clinical care, lived for a long period of time. But he years and years where we had CSFs, he never cleared that infection.
Never had a negative CSF.
Yeah, so and so that tells us we need to know more about why And even in the face of IRIS, we may dampen down the copy number we see in the CSF, and we have sequenced this to see if it changes over time. And there's more to do on something like that. So I think your question, do you have longitudinal taps on this? I think that would be very instructive and very helpful in terms of then specifically saying, what do we need to know about, in my humble opinion, the T-cell responses that's going to target that one. And once we know that, then I think we can take a leap into interventional kind of immunotherapy.
Beautiful comments. And by the way, David and Mila, I have one recommendation on the title, and that would be, compared to a lot of cases with PML with IRIS, where it's quite profound and highly conspicuous, yours is really a beautiful example of clinical radiologic paradox in PML. Again, different subtype with the GCN, but this is a clinical radiologic paradox. You had a big league exam to the right localization you all talked about, and yet you had to look very hard. I had this monitor almost right up in my face as I was trying to look through these track systems and the Foley, and when you had the vertical arrangement of upper versus lower, you could really strikingly see it, again, underscoring Mila's point about looking at your own films. But one part of the subtitle here might be that this is, in a sense, a PML clinical radiologic paradox. We're used to seeing a lot of destruction.
Right. Elliot, is there time for David to tell us a little bit about what we did and what happened with
Yeah, please, go for it. We're a couple minutes over, but go ahead. We usually break at like 6, so go ahead.
Yeah, we're okay. So I'll just go. Let's see. Yeah, I've got a little bit. Just one last interesting slide before I get back to the case, and that was the last case presentation of the 4 that I mentioned before. This group used FDG PET to actually identify that there was hypometabolism in the cerebellar tracts, and that was a way in which they were following this patient as well. So back to our patient. We're moving on in time. So he was admitted to UVA on March 8th, so, as soon as we had a positive titer, and he underwent treatment with plasma exchange on the 9th. We were fairly anxious about induction of IRIS, repeated his MRI 2 days later. That it was essentially unchanged. I have them all on the next slide to look at. At that point, we felt a little bit more comfortable clinically. He wasn't doing great, but he was stable in his cerebellar features, and so he underwent 2 more treatments with plasma exchange. I saw him back the next week, and by my exam, he seemed worse. He